Hello again. The lecture that follows is on histiocytic disorders involving the bone marrow. Now, this is a group of disorders which are not particularly common. In fact, they're not common disorders in any tissue, but they are quite uncommon in bone marrow. However, they are important lesions because almost for certain, if you do hematopathology in your practice, and particularly bone marrow pathology, you will encounter these lesions from time to time, and they can be diagnostically problematic. So it's important that you have some knowledge of them. And I'm not going to do an extensive review of all histiocytic lesions or histiocytic lesions that may, in very, very rare instances, involve the bone marrow, but I'm going to focus rather on three categories of histiocyte lesion listed on this slide that do involve the bone marrow when, although they're rather rare diseases, when they are present, they involve the bone marrow in a rather high frequency. And those are the storage diseases in general, and I'm going to only focus on three of them that we will discuss, and they're the ones we see most often and which may be diagnosable in bone marrow biopsy, or at least suspect in bone marrow biopsies. The Langerhans cell histiocytoses and the hemophagocytic syndromes. First of all, the storage diseases. Now, how do the storage diseases manifest symptomatically in terms of the hematopoietic organs? Well, most commonly, what we'll see and why we end up doing a bone marrow biopsy is the cytopenias that are associated with some of the storage diseases. And this can be on the basis of two separate mechanisms. One is that these diseases tend to proliferate in hematopoietic tissues. So we see large spleen in many of these patients, and in some cases, the large spleen leads to hypersplenism and destroys or removes cells from the circulation. And if this can be extensive enough, we might see cytopenias as a result of the large spleen. The other is lesions involve the bone marrow and encroach on normal hematopoietic tissue, disrupting it and causing cytopenias and other manifestations in the blood. Another way in which patients with storage disease may present is with tumor-like masses. They may have lymphadenopathy, although not that common, but splenomegaly and hepatomegaly may be more common. So tumor-like masses in hematopoietic organs. And lastly, and importantly, there are certain of the storage diseases that result in inclusions in various blood leukocytes. So leukocyte inclusions are another manifestation of storage disease. So we end up doing a bone marrow. Now, the first I'm going to talk about is the one that is the most common, actually, and the one that can be diagnosed and often is on the basis of a bone marrow biopsy as the first tissue or the first indication that the patient has Gaucher's. There are three types of Gaucher's disease. The one that we most often would encounter in the marrow and make a diagnosis of Gaucher's disease is type 1, or chronic non-neuronopathic Gaucher disease. Type 2, acute neuronopathic, is usually manifest by very severe central nervous system manifestations, which lead to diagnosis based occasionally on bone marrow biopsy, but usually on testing for the deficiency of encountered in this disease. And the third type, subacute neuronopathy, is usually also diagnosed in rather young children. They also have neurologic manifestations, which are usually the first tip-off of disease. Okay, well, let's look at a blood smear from a patient with type 1 Gaucher's disease. This is actually from a 24-year-old woman who presented with cytopenias of a mild to moderate degree, but had an enlarged spleen. So bone marrow was performed to assess for the cytopenias. And in the bone marrow aspirate, there was a cluster of big cells found on the feather edge of the smear, illustrated in this slide. And we see this very strange internal cytoplasm geographic material, which is very unusual. And on our bone marrow biopsy sections, we see a space occupying lesion, or several space occupying lesions of these big cells, which on the right at higher magnification, some have multiple nuclei, others are just large histiocyte looking cells. We don't see in this particular case dramatic illustration of the crinkled tissue paper type appearance that is described for these cells, but we see a lot of big histocytes encroaching on the hematopoiesis, and we still do have a lot of residual hematopoiesis here in this bone marrow. So clusters of large histocytes separated by areas of normal marrow. Now when we put a PAS stain on these cells, it really brings out these inclusions in the cytoplasm that give it that crinkled tissue paper look in many cases. So PAS stain can be helpful to really dramatize this finding when you don't see it as well in your H&E stains. So that's one very classic biopsy in a patient diagnosed by bone marrow biopsy of type 1 Gaucher disease. Here's another one. Once again, a patient who was not diagnosed until age 35 when they sought attention for a compression fracture of the vertebrae. They'd had a previous compression fracture of vertebrae when they were 29 years old, and it wasn't further evaluated, and the patient got somewhat better. And that was the end of the workup. Now, a compression fracture that's not traumatic, it's with significant trauma in a 29-year-old man is a pretty unusual thing, and really suggests that you should probably work up the patient more carefully. But at age 35, the patient was worked up, and what we see here is a lesion in the bone marrow in which we have these histocytes, but some of them seem kind of degenerative. Others seem pretty good, actually, for Gaucher cells. And then we have these kind of spindly cells over in the left, which are part of the Gaucher infiltrate. At higher magnification, we see some of the degenerative features of these cells, and in this area of a biopsy, we see frank necrosis of the cells. And this is a well-known phenomenon that can occur in Gaucher's disease, where they undergo infarction of not only the Gaucher infiltrate, but in the bone. And it can lead then to pathologic fractures. Now, not all that looks like Gaucher's in the bone marrow biopsy is, and this is a striking example. I think these lesions look very much like the lesions that we saw in our first Gaucher patient. This patient presented, once again, a young man in his 30s with no particular history except had cytopenias and had splenomegaly. So we did a trephine biopsy, and at first glance thought, is this histocyte proliferation? Could this be Gaucher's? Well, we also learned during the course of evaluation of this patient that he had not only blood cytopenias, but had a very low CD4 count. He was tested for HIV and was positive. We did a fight stain for Mycobacterium avium intracellulare, and here it is. And these histocytes are just teeming with organisms, which of course you couldn't see with the H&E, but this patient had Mycobacterium avium infection and was HIV positive, but was diagnosed for the first time with HIV based on this finding. All right, let's look at patients with Niemann-Pick disease. Now, these aren't as specific. The Niemann-Pick cells are foamy histocytes, but they don't have a distinguishing feature that differentiates them from foamy histocytes you can see in a lot of other conditions, including some patient with hyperlipidemia, where we'll see foamy histocytes in the marrow. These smears, however, were from a young child, only about 1.5 years of age, or 2 years, and a bone marrow aspirate was done. The patient had hepatosplenomegaly, and in the bone marrow aspirate, you see these scattered foamy histiocytes. In the biopsy section, we once again see scattered foamy histiocytes throughout this biopsy section, and simply mixed, not forming lesions, but mixed in with the hematopoietic tissue. This patient had a splenectomy, had a huge spleen. Spleen was taken out, and here is the spleen, and once again you see, here you see sheets of these large foamy histocytes. So not specific, but a clue in this circumstance and in this age group that maybe we should look for storage disease and specifically focus on Niemann-Pick. Now, there are several variants of Niemann-Pick disease, so it's really Niemann-Pick diseases with different enzymes being involved or lacking, and different mutations. So the patients need to be worked up and characterized. They vary a bit in severity, but this patient had one of the variants of Niemann-Pick. Another disease we encounter in bone marrow and blood is mucopolysaccharidosis. And what we encounter in the mucopolysaccharidosis, of which there are about 7 variants of mucopolysaccharidosis, Hurler disease being most common, then Hunter, Sanfilippo disease, and so on and so forth. But what they have in common is many of them deposit mucopolysaccharide in various hematopoietic cells, including lymphocytes, monocytes, and even granulocytes. And here we have examples from 2 different patients with lymphocytes with inclusions in the left, the classic, described as looking like Chinese letters. I think they only look like Chinese letters to somebody who does not speak or read Chinese, but in any case, that's how they've been described in the literature. And they have these very profound vacuoles around the mucopolysaccharide inclusions, allowing their recognition. More subtle on the right, we see just dots of mucopolysaccharide inclusion, and these actually look like those you might see in a large granulated lymphocyte. The difference being they're all in kind of a lacunae of clear area around the granules. In the bone marrow, you may see inclusions in a lot of the hematopoietic cells. These happen to be in a patient with Sanfilippo's disease in histiocytes in the bone marrow, but you see these very characteristic mucopolysaccharide inclusions in abundance. You can do a toluene and blue stain and on these patients, and they stain metachromatically with the toluene and blue stain. Okay, so there are other storage diseases that may involve the bone marrow, or you may cause inclusions or vacuolation in blood cells, and if you are interested, they're all rare. If you are interested in this, I would suggest you do some reading in a standard textbook on the subject. Okay, let's move on into Langerhans cell histiocytosis, and this is a histocytic proliferation that very frequently involves bone marrow when it is in either a multifocal or progressive disseminated form, and also involves the bone, but more commonly as focal lesions in patients with eosinophilic granuloma. So in eosinophilic granuloma, we'll usually make the diagnosis in marrow through a directed biopsy to a site that has been identified radiographically. But in multifocal eosinophilic granuloma or in progressive disseminated Langerhans cell histiocytosis, we may see disease in random posterior iliac crest biopsies. So the bone marrow findings are rather specific, but can be, as we'll see, confused with other lesions which enter the differential diagnosis in some patients. Most commonly, the diagnosis is made or suspected based on biopsy of other tissue, especially the skin. But in some instances, the primary diagnosis is made on the basis of bone marrow biopsy performed for blood cytopenias in particularly a child. The aspirate smears may show increased histocytes out near the feather edge of the aspirate smears. The histocytes may show features of Langerhans cells in smears that make one suspicious when you see clusters of these and they have the characteristic nuclear features, but they're easy to overlook because you usually don't aspirate many of them in the aspirate smears. However, in the tree-find biopsies, you may see focal lesions consisting of a polymorphous infiltrate, or you may see large confluent lesions, and they may consist predominantly of just Langerhans cells. This is an aspirate smear of a patient with marrow involvement with Langerhans cell histiocytosis, and we see some of these big histiocytes. They have these funny elongated grooved nuclei that we see here, and we see a background plasma cells and some broken nuclei from other Langerhans cells, another one in the upper right hand corner here. So this is about as good as it gets on smears, but on tree-find biopsies we may see some more characteristic appearance. We see a polymorphous infiltrate around a proliferation of Langerhans cells that have the typical grooved nuclei, very characteristic Langerhans cells here. Looking at this, it should be the first thing that comes to mind, but we also have eosinophils out here and other cells in this somewhat polymorphous infiltrate. Okay, so that's a good example of a lesion. Now, what we would do is stain it, because we want to make sure these are Langerhans cells, number one, and would use various stains, but usually the top three on this list are the ones we'd use today to nail down a diagnosis of Langerhans cell histiocytosis in the marrow. CD1A and Langerhans cells should be positive. S100 neuroprotein, also positive. Langren, which is a very good stain for Langerhans cells, and pretty much only stains them. The other two, of course, will stain other cells. CD1A, of course, stains thymocytes, stains T lymphoblastic leukemias, and S100 stains a bunch of things, including melanoma etc. But Langerin is pretty specific. They also stain positive for Vimin, as does a lot of other things. They're HLA-DR positive, but they're negative for those stains that we see in phagocytic histocytes, such as the non-specific esterase and alpha-1 anti-chymotrypsin or alpha-1 antitrypsin. On the left, we have an S100 stain and a lesion from the bone marrow of Langerhans cell histiocytosis. On the right, we have a CD1A. Now, the CD1A in this case is faint. I don't think the stain was quite as good as the one we have now. This was on a case I photographed a few years back, actually. But we see these cells staining with 1A. We know they are Langerhans cells. And sometimes the Langerhans cells will only be a small portion of the actual, or occupy a small portion of the actual lesion. So here's CD68. It stains histocytes, also can stain Langerhans cells, but most of the cells staining here in this same lesion are not Langerhans cells. They're actually histiocytes as part of the polymorphous infiltrate. And then we see the Vimentin staining the Langerhans cells in this lesion very nicely, but it's sensitive to Langerhans cells, but it's not very specific. Another method of diagnosing or recognizing Langerhans cells is electron microscopy. We don't do this much anymore, but electron microscopy identifies the specific organelle that we see in Langerhans cells, which of course are these Burbeck granules. Very characteristic structure by ultra structure. We see some on cut across, others we see the elongated granules here, and they're very characteristic of this disease. All right, what's our differential diagnosis of Langerhans cell in the marrow? Well, granulomas, interestingly enough, because they've got a lot of histocytes, and particularly if you're suspicious of Langerhans cell histiocytosis and countergranulomas, you'd want to stain it to rule it out. Other histiocytoses, including perhaps in children, some of the storage diseases we've discussed, and the disease we'll discuss next, which is hemophagocytic syndromes. But also Hodgkin lymphoma, polymorphous infiltrate with a lot of histiocytes in it, and actually a few Langerhans cells in the lesions sometimes, and mast cell disease, which can look very much like, if you don't recognize you're looking at mast cells, can look very much like histocytes, and you have polymorphous background and focal disease in the marrow and skin disease. So both clinically as well as pathologically in the marrow in a patient not diagnosed on the basis of other tissue, there can be a differential diagnosis issue between Langerhans cell histiocytosis and mast cell disease. All right, so let's go on to the last one that we're going to talk about in any real detail, and that's the hemophagocytic syndromes. These, like the other histiocytic lesions, are not really common disorders, but they are challenging diagnostic disorders and may be difficult to diagnose initially when you first see a bone marrow biopsy in a patient with one of these hemophagocytic syndromes. They are of two major types: the infection-associated hemophagocytic syndrome, which we see a bit more common than the familial hemophagocytic lymphohistiocytosis. The infections are generally caused by a virus, and especially EBV. EBV is associated with a lot of things in hematopathology world, and infection-associated hemophagocytic syndrome is yet another one. It is possible that the familial hemophagocytic syndromes really don't manifest themselves until patients encounter an infection usually with a virus, which they are unable to deal with, and then this genetic abnormality becomes manifest. What are the features of the hemophagocytic syndromes? Well, they're pretty much the same in both, at least many of the manifestations are the same in both the familial and the acquired or the infection-related hemophagocytic syndrome. Patients have fever, sometimes high fever, and it's persistent. They have organomegaly, especially splenomegaly and hepatomegaly. Pancytopenia, sometimes very severe. Liver function abnormalities with sky-high liver enzymes in some cases, and a coagulopathy in which they become hypofibrinogenic and actually show manifestations similar to a disseminated intravascular coagulation. Lab studies of interest are the finding of elevation of triglycerides and also elevation of other studies that can point to the diagnosis of this disorder. Now, there are a number of, I'm going to talk first here for a few minutes here of the infectious-associated hemophagocytic syndrome, and there are a number of infections that can be associated with this phenomenon. Viral being most common, but also certain bacterial infections, mycobacterial, fungal, rickettsial, parasitic. Almost everything has been described in some individuals as inducing this kind of strange hemophagocytic syndrome. So it's usually diagnosed in a bone marrow, and we do a bone marrow biopsy, and we characteristically will find histiocytic hyperplasia, and then we note that there's hemophagocytosis of different types of blood element. Red blood cells, nucleated red blood cells, neutrophils, platelets, lymphocytes may be seen in the cytoplasm of these expanded phagocytic histocytes. We also see background bone marrow destruction with proliferation of histocytes, what appears to be alteration of the normal bone marrow stroma. The marrow may appear hypercellularity because of all of the histocytes present, but the actual hematopoietic tissues, especially granulocytic and erythroid precursors, are diminished. Megakaryocytes, in contrast, tend to be normal in number or even sometimes increased, even though the patients may be markedly thrombocytopenic. Occasionally we'll see other more non-specific things like little granulomas or lymphocytic aggregates in the marrow. On the bone marrow aspirate smears, as illustrated in this slide at low and high magnification, we see sheets of histocytes, and we are most likely to find these out near the feather edge of the bone marrow concentrate smears, where we just see sheets of them. And at higher magnification on the right side, we see that these are phagocytizing red cells, nucleated red cells, and platelets in this particular instance. Also, in one of the histocytes in the upper right corner, we have a granulocyte precursor. Another case showing phagocytosis, once again, of nucleated red cells, of platelets, and of red blood cells. The bone marrow sections show the phagocytosis as well, but it can be a little more difficult to recognize sometimes. But as you see these clusters of red cells here that are sort of strange looking, it's because they're in the cytoplasm of histocytes, and there's marked red cell phagocytosis as well as platelet phagocytosis in this case. Other cases, you'll see a proliferation of histocytes, and the phagocytosis is not nearly as obvious, but we see some debris in the cytoplasm of at least some of these histiocytes. I mentioned earlier the bone marrow destruction phenomenon, where you see the stroma of the marrow looking very abnormal, and actually see areas that kind of look like fibrinoid necrosis here. So it's a ratty looking marrow. We see a lot of there's a big histiocyte here on the right side panel with the arrows circling the cell, and we see nucleated red cells in the cytoplasm, more in the cytoplasm here. Here's a big old histiocyte just filled with these nucleated cells in the cytoplasm. Okay. So what causes this phenomenon? The morphology in the bone marrow can look very similar, whether it's the familial type or the infection-associated type. But what causes this? Well, until the last dozen years or so, it wasn't certain. We knew that there was an autosomal recessive inheritance pattern in the inherited form of this disease, but what was the abnormality was really not known until about a dozen years ago. But it is quite clear that there is a genetic-based molecular defect in immunoregulation. We've known for some time it's an autosomal recessive inheritance, and the homozygous mutation which occur and was discovered to involve the perforin gene through a very, very interesting story, which if I had time today I would tell you, because it happened right at the University of Texas Southwestern Department of Pathology, where I was a number of years back when this was first identified by Dr. Vinay Kumar and a graduate student of his in his research lab there. But we won't go into detail, except it was identified that in the inherited form of hemophagocytic lymphohistiocytosis, perforin gene mutation appears to be the single most common cause. An absence of perforin leads to defective cytotoxic activity in these patients and leads to an uncontrolled activation of T lymphocytes and NK cells and macrophages with associated overproduction of inflammatory cytokines. And this results in biologic havoc in these patients. Here is a lymph node biopsy from a young child who had a perforin gene mutation, homozygous mutation, which led to the absence of perforin in the granules of the cytotoxic T lymphocytes and the NK cells, which stimulated increasing production, increasing numbers of cytotoxic T cells, and elaboration of cytokines by the T cells, stimulating histiocytes, which elaborated further cytokines, leading to this marked hemophagocytosis and destruction of the multiple organs that occurs in these patients. The sections of the lymph nodes here show a CD4 stain. CD4 cells are present and present in normal number. But the CD8 cells in this lymph node are profoundly increased, as shown in the right panel. A TIA stain shows markedly increased lymphocytes, the cytotoxic T cells containing the TIA, but a perforin stain, which should also be present in these cytotoxic granules, is completely absent in expression. All right, so we know that most cases of the inherited form of hemophagocytic lymphohistiocytosis result from a gene mutation, a perforin gene mutation. What's the cause? of the acquired form, which may occur in older adults even, and patients that are young that get infected with EBV or some other virus. What is the mechanism here? Well, it's not clear, but probably it's a very similar mechanism. We have T cell dysfunction with excessive cytokine production, from an abnormal feedback regulation, and unchecked cytokine production with marked histiocytic proliferation and basically the same sequelae. Now we know that some patients that develop an acquired infection-associated hemophagocytic syndrome have some sort of immune deficiency. The first cases that were described of this disorder were actually renal transplant patients at the University of Minnesota. And it was noted that some of these patients developed this disorder, and if their immune suppression was relieved, even though they would generally lose their kidney at that point, they would get over it. If their immune suppression was not relieved, they would die of the disease. It was later discovered in a cohort of Chidiakagashi patients that died and went to autopsy that they had the same findings of infection-associated hemophagocytic syndrome. And this was identified at this institution and published. Furthermore, the X-linked lymphoproliferative disorder, which was, by the way, discovered by a former resident from the University of Minnesota, Dr. David Pertillo, and one of the things that he identified was that as these children get older, they develop this histiocytic proliferation and die when they first encounter an EBV infection. We do see it occasionally in AIDS patients, but not often. And then there are other virus infections, and presumably through mechanisms not well understood, immune suppression that occurs maybe directly from the virus infection that leads to this abnormal type of reaction. Maybe there is a defect that is similar to the familial hemophagocytic syndromes, but less severe, or in patients that are only challenged at some much later time in life. Another thing to be aware of is that in some T-cell lymphomas, there is an associated virus-associated hemophagocytic syndrome. This was first a paper described back in 1992 on this finding by Dr. Peter Banks, another former resident or fellow in surgical pathology from this institution. And he identified it in T-cell lymphomas. The ones that it is most commonly seen in is in paniculitic-like T-cell lymphomas, but may be seen in others as well, and also in aggressive NK and a nasal type TNK cell lymphomas. Okay, just one word in conclusion here about malignant histiocytosis. What we have discussed are these proliferations that, for the most part, although Langerhans cell histiocytosis is clonal, is sometimes self-limited or in most instances responsive to treatment. There have been diagnoses made over the years with the designation of malignant histiocytosis, and you may encounter this particularly on a literature search of some of the older literature. Most of the diseases that were in the past called malignant histiocytosis are now identified as being some other disease. Some of these were monoblastic leukemias that presented as tissue infiltration, basically as myeloid sarcomas, and were biopsied and called malignant histiocytosis. I'll show you an example of one such in a minute. And then what the disease, which was probably the two diseases which were most commonly called malignant histiocytosis, were disseminated forms of virus-associated hemophagocytic syndrome before it was identified that this is in fact an abnormal reactive process, and anaplastic large cell lymphoma before it was identified that it is in fact a T-cell neoplasm. These were both designated frequently as malignant histiocytosis. Now there are localized true histocytic lymphomas that still do get diagnosed occasionally, but usually not in bone marrow, more commonly in soft tissue and other sites. This is an example at high magnification of a patient with monoblastic leukemia that presented and had a skin lesion. It was biopsied and it was called malignant histiocytosis at the time, but the patient developed a monoblastic leukemia in a few weeks and was in fact an example of a kind of differentiated monoblastic leukemia. Okay, well, that's the end of this lecture. Once again, thank you so much for your attention